Good morning and welcome back to Mount Sinai here in New York City. We are pleased to have you join us again for our little Christmas special. Here we have a very nice,
need the radio
complex, multi-level
radio
CTO
access needle.
case that is being taken care of by our very own Dr. Prakash Krishnan and Dr. Vishal Kapoor. Since it looks like we may have a lot of work to be doing today, so I think we'll just jump right in. PK, Vishal, what do you got for us today?
See this and you're like, what's going on? So anyway, first of all, welcome to Mount Sinai. Wish all of you a happy holiday wherever you are. Hope everybody is safe and well in this nice season. I'd like to introduce our team. To my right is Dr. Vishal Kapoor. All of you know he's the Director of Endovascular Service at Mount Sinai Morningside and the Associate Director here. You've got to my left is our very own Ray Lascano. Been with us for 99.9% of these cases. I think he missed one because of vacation, and or birthday or something like that. To Vishal's right, we've got David Song, our endovascular fellow this year, and we've got Elizabeth and we've got Habib here with us, and we're ready to go. And sorry. On Ramon as well. Yeah. So we're ready to go here. We've got a great case that you can see we're already struggling with. So we're going to have David present the case to you, Raman, and we'll get started.
A lot of varicosity.
All right, next slide, please. So this is a 67-year-old gentleman referred for bilateral lifestyle-limiting claudication, progressive to ischemic rest pain, left greater than right with less than one block of activity, Rutherford Grade II, Category 4. He has polyvascular disease. He has CAD, stats post CABG. It was complicated by a complete heart block, so he had to have a pacemaker implanted. He has ischemic cardiomyopathy. He has subclavian thrombosis, also a popliteal vein DVT for which he's on lifelong anticoagulation with Coumadin. He has peripheral venous insufficiency, status post ablations, and he has the common comorbidities of hypertension, hyperlipidemia, and diabetes. He is never a smoker, and at home he's on Warfarin, Plavix, and good medical
Can you
therapy.
operate this for me? I suck.
Next slide, please. His non-invasive diagnostics were done at an outside facility. He has very abnormal ABIs. On the right, he has ABI of 0.64. On the left, he has ABI of 0.50. In terms of a left lower arterial duplex, the most significant finding is on the left. There's a popliteal artery, essentially a total occlusion, with distal below the knee disease on the left as well. Next slide, please. So he has had a peripheral angiogram before. This is the left runoff. The SFA is okay. Essentially, what we see is that there's a significant left popliteal total occlusion that reconstitutes distally via significant collaterals. Actually, next picture.
It's hard to.
So this is just a close-up shot of the total occlusion on the popliteal. Next, please.
Go higher. Oh yeah.
This is essentially showing that the below the knee vessels reconstitutes via collaterals. The major tibial that reconstitutes is the anterior tibial artery, which runs directly to the foot and gives off collaterals to fill the peroneal and also the PTA. Next, please. So our access right now is contralateral right CFA access, and we're also attempting left pedal access, potentially atherectomy, atherotomy, and destination therapy for the POP is DCB versus Stent, below the knee, PTA versus atherotomy.
So, Raman, I mean, you've got a multi-level disease. If you can go to us, Ray's going to show you the iliac. The iliac was a little tortuous, not much issue getting through, up and over. We went with a 7 French because of since it's a live case, as you know, we generally tend to go with 7 French. Just for visualization. And then, so down below, you can see the SFA is a large ectatic vessel, probably an 8 millimeter vessel or even 9 possibly. And then you can see here below knee, the AT comes back, the PT is occluded, but you can see it in the foot. And then you can see here, you've got the AT giving rise to the DP as well as a little bit of a short DP occlusion in the foot, but overall very good flowing, and the arch also fills. So he's actually a severe claudicant. He's quite young, as you can see, is a good candidate for a short bypass. Does not have a vein, so our guys decided to try to just do this with our traditional approach, with the idea being not to mess up the distal vessel, so that if he does need a short PTFE bypass, we could do it. He does so at this stage. We've got a multidisciplinary team approach, and what we're trying to do is get through up and over. The idea would be antegrade and retrograde because of the difficulty of this occlusion. It's very calcified, as you can see. 100% not an acute occlusion, as was read in the ultrasound. I don't know why it was read like that, but we're trying right now. So our plan is up and over. We are up and over the 7. We've got a angle tip catheter. Go next, Ray. I don't know if we saved it. Yeah, so we have an angle tip catheter trying to find the nubbin. We think that's the nubbin right there. Next, please. And then we went ahead and we tried to probe this with both an angle glide, and you can see there's no hibernating vessel there. We tried to probe this with an angle glide as well as a stiff glide. And so maybe Ray saved that, I'm not sure. So as you can see here, Raman, I'm going, Vishal's trying to get pedal access. I mean, I may just stick it under a fluoroscopy,
right there.
but
Give me one.
Right now, I'm just trying to find the nub, and we.
Sorry.
Okay,
Give me more Lido, please.
Obviously, he's having a lot of pain.
Sorry. Give more Lido.
A little Lido, guys. And I'm just trying to find the nub in here. So there you go. We got into some nub in there. All right. So now I'm just gonna try to keep poking this through as much as I can here.
Now, as of right now, you have.
Hold it.
Looks like you have just the catheter. Is that correct?
Yeah, because I'm trying to find the right spot, and now I'm going to go with the stiff angle glide, which is right here.
Little burning, sorry.
So I'm going to go with the back end, Raman, because the front end doesn't seem to work. So I'm just going to go with the back end of the stiff here.
So let's a couple talking points here. So this is a pretty complex CTO segment. It looks like there's a short nub, which makes the proximal cap appear as though it's slightly favorable. The distal landing zone is actually quite unique. It almost goes all the way up until the ostium of the AT, but interestingly, it also seems as though the peroneal comes all the way up to the end of the TPT. So my question is, for this pedal axis, did you choose the AT or the peroneal?
We chose the AT because it's a direct shot in, but obviously we're having a little bit of trouble getting in. It's a robust vessel. We should be able to get in under fluoroscopy if we cannot get in any other way. Are you able to? You don't have flow?
I have flow, but I don't want to wire without the.
Yeah, because what I'll say is that if for a vessel where it's like this is the dominant vessel going down, would it be worthwhile to go by one of the ones that's already that's already occluded, and try to access from that point as opposed to trying to.
We talked about it, but
this vessel.
I don't think you're sacrificing it. I think we're just going to use a O1A catheter to try to cross. We're not going to put a sheath in at this stage. And even if we put a sheath in, it's going to be a large vessel that we're easily going to be able to put a 4-5 slender in. I just want to make sure there's something going on with my wire. It's not going up and over. Last time it went easily up and over. So I'm just going to make sure that it goes. I'm just trying to see what's happening here with the stiff glide. Sometimes they don't go, and it's not going now for whatever reason. Give me a little negative, Ray. Let me pull back a little. Nope. See, now it just went. Now it's not going. Wow. All right, so stiff slide's not going.
But that was the back end of the wire. Is that correct?
Yeah, that's the back end of the wire. And sometimes it doesn't make it. Let me just stick it. I mean, let me just do it under fluoroscopy.
Yeah.
So I'm just going to stick it under fluoro. We're not able to get it with ultrasound. Let me see.
Here, right there. See, it moves.
So if you can do it, let's just do it.
Yeah, I am.
The only reason why I was also suggesting the peroneal is because then you would almost get 2 vessels for the price of 1.
No, but the problem is if you see the angulation, Ray, play the film for him. If you see the angulation of the PT coming in, you may actually lose the AT when you fix this perineal, and you may get flow through only the PT to the foot. The idea would be
peroneal.
It's not really the perineal, it's the PT that's the occluded vessel. See that coming up behind right there, that's the robust PT right there. You see that?
So I'm talking the one that's right overlaid over the AT.
Yeah, but I mean, to get the perineal, I think will be more difficult than just getting the AT. He's having a lot of trouble here.
Oh, look, there's my vessel. Right. See. It rolls. That's why it is.
Right. Let's see.
The problem is just.
Yep. Take your time.
Yeah. There's no blood coming out of this thing.
There it is. Now he's in. Hopefully now the wire will go.
Give me another.
averted catheter.
There it is. Now we're in the vessel. All right, put the dilator in and give some stuff, guys. Careful.
Yeah,
That's what you don't want to do.
Yeah.
That's the
Okay,
occluded
I'll just leave
segment.
it right
Yep.
there.
Put a dilator in,
Here you go.
and let's
Just
get
the
some
dilator, right?
vasodilators.
You want the whole sheet or just?
No, just the dilator right now.
Yeah.
And then get me a
So this
V18,
is-
guys, and give me a 018
Can you give
Trailblazer.
me,
So we've got this
give
just
me
a dilator
2.5
running in, so this way we're not really messing up
give
with the
me
vessel.
100 of that.
We're going to give our vasodilators, and then we're going to go with the V18, and hopefully we'll be able to cross this from below and then re-externalize it, because the stiff end of the glide wire is not crossing from above.
Wow.
Now, as far as your algorithm here, what made you
Can I have the?
kind of deviate so quickly away from kind of going down your wire sizes towards your CTO wires?
Oh, because we tried. Yep, we tried all the offline, because we knew when I saw the blunt stump, we tried each one, and that's why we're ready to put a 5/6 slender in here to go with a glide wire from below, even a stiff angle glide from below.
Got it.
So at this stage right now, we're just giving the vasodilators, and then what we're going to do is give us a V18, guys.
So
V18 is here.
Okay, so we're going to go with the V18, and give me a 018 Trailblazer.
Sorry, it burns a little bit.
should be
Sorry.
indeed.
So, Michelle, what's in your little cocktail there? What have you
Same
given
thing.
so
Like we
far?
try to use the 2.5 verapamil, 100 of nitro. The patient is already anticoagulated, so we didn't give any of the stuff. A little burning.
Was this the patient from
Give me the V18.
our Thanksgiving episode where he had taken the Coumadin the day of?
Exactly, the same guy.
Okay.
The same
We have to shape
dude.
it. Hold on,
You know,
hold on,
we'll
hold
just
on,
go
one
up
second,
first. Let me see.
me
It's the same guy
Yeah.
from our Thanksgiving episode. Let me see.
Let me mag out a little touch for you. Make your life easy. Oh, the II is. Oh.
Okay, so here we go.
Right, got it. I got it.
All right, give me the 03 or the 018 Trailblazer here, guys.
Yeah.
That's our cap right there.
Look, there you are. You're going down into the
There
TP
you go.
trunk from
Yeah.
over there.
Yeah.
Yeah, that's not it.
there's-
No.
It could be. Who knows?
Yeah, that's better. Yeah.
Well, let's just leave it there for
There.
now.
Yeah.
Let's get the Trailblazer in now.
Trailblazer is ready. Let me hold it. You
Got it.
Perfect.
So I don't think the wire
035
escalation
natty.
strategy is going to work from above, because we tried the
035
018
natty class.
and even the 035 straight was not able to break the cap. So I think what we have to do is come from below and then break this cap from below, and then try to go. So we need some different wires from here. I chose the V18 Raman here because I think at this stage I just need to get a support catheter in. Once I get a support catheter close to where I want to be, I may just go ahead and switch out to different wires here and then go forward. So as the catheter goes up here, I'm just gonna have them I'm just butt this here, and then I'm going to go ahead. Ray, can you
hold
get ready
pressure.
from above to inject?
Yeah, I have it.
Hold on.
Yeah,
Let's get the shield in front of you guys.
I think
I think
for
it's
me
catheter's
the
compromised.
first
blood.
wire choice
pull back.
coming down from below for me is routinely always the V18.
Probably about it.
So it's always a great
You can just
start.
inject the other way, Ray. Just from the side sheath, and just pull that back and flush it if you have to. Ready?
It's good. I got blood coming out of it.
All right. Let's go ahead and do a quick roadmap. Pull the thing, protect yourself with the radiation. So ACT is around 300 right now, Raman. Over 400. So we're in the right spot there. I like that, right? And so now we're going to go ahead and just pull this wire back here and try to push the catheter up, Vishal. So we're going to try to get a butt against it, but obviously it's not. No, pull back a little. Give me a CTO wire here, please, like a coronary CTO wire, like a Confianza. I'm going to try to do a dissection here.
You want a new Confianza?
Doesn't seem to want to
No,
work.
no, it's a blunt.
Yes.
Same Confianza. So these blunt dissections are going to be very difficult. Actually, guys, give me a Connect 250T here.
It's right here.
Let's go with 018 system here, because it's just laughing at everything. So I'm going to go with an 018 and give me an Estado 30 as well.
Yeah.
Yeah,
Don't
this
open
is
the
this
Estado.
is overall, is about as hard as they really get. When the distal reconstitution is also equally unforgiving. That's the original CTO segment. Because I feel that distal pop, the P2, P3 segment may not be as straight as we're thinking, considering the way how your wire went into some odd channel. And this I think this proximal cap, I guess, from the retrograde approach is very it's very ambiguous.
Yeah, for the C-top classification, yeah, definitely.
like
it's just
it's
most
still not-
unfavorable category 4, like you said,
Yeah.
blunt top, run from the back. I mean, the distal end.
Yeah. But the question is really is that how far from the ostium is this actual AT? And that's hard to really tell, considering how far your wire is going in a assumed trajectory towards.
But I think we got it already.
Yeah, no question, you know.
And see some.
And the catheter is right there, so we're quite
point
far
out.
away. But you know, I'm not worried about blunt dissection here. I think we just need to figure this out a little bit. I just have a little target there for you
A
guys.
little bit more bend
All
on
right,
the
let's
wire.
just see if we.
Starts to turn up, then I'll be a little bit more promising.
Well, let's
I think
see.
a little bit
let's-
more-
Well,
you
we're
wanna
going to
push it?
dissect this, right? So I'm just going to go ahead and get this up a little closer here. Give me a command wire here, guys. A command 18. Command 18 may
Yeah,
be
I
more
think
favorable here to
Yeah,
dissect.
the
Command 18.
the bend is a little bit less.
So we know there is a microchannel. Is my pressure okay, guys?
Yeah.
Okay. So I mean, our wire escalation right now is just to break the cap, and I think we've got some channels here. So now I'm going to go ahead and go with the command if Habib can find it, and then if he finds the command, we'll go ahead and do it because I need a little bit of torqueability with this wire.
Yeah.
So all right, can you give me any command wire, please, if you can't find a command wire? I mean, where's my Abbott people? Yeah.
Yeah, like PK is talking about, command 18 is like the extra supports. It gives you the body as well as the hydrophilic end. So I think what PK is trying to do is just find that loop and just try to see if you can just direct it more up towards the distal cap.
You know, there are other
proximal cap, I
catheters
guess.
that we're supposed to have that we don't have, like the wingman catheter. You know, we have it?
We got one.
Oh,
We
can I have
found
the
one.
wingman?
We
Can you
found
grab
Oh,
it?
we found one.
What do we have? 014 or 018? Or 035? Okay, give me the 035 wingman. We're going to go from above too.
All right.
So, Raman, maybe you could describe the
nice,
wingman catheter.
Yeah. So the wingman catheter is from
Yeah,
Reflow.
Ray will do it.
From Reflow Medical. Pretty smart idea. Basically, there's a catheter that is an over-the-wire system, but at the end of it, there's a needle bevel that's torqueable. And from the back end, you're able to gain access towards your proximal cap over the wire. And then as you remove the wire, you can actually drill with the needle, the
What do
bevel
you
needle, into the actual CTO segment, kind of paving a path through the actual occluded segment, and then advance your system and kind of like millimeter by millimeter slowly make your way across. They have a straight edge version,
it at
an
the foot?
angled version.
No.
It's a very it's a very interesting concept device as far as what you're doing, the drilling through the actual cap, because at the back end you physically take the needle and you kind of rotate it to actually drill
This is soft,
the
nice.
bevel at the distal end of the catheter system. It certainly is one that could be quite promising if you were to approach it from that proximal cap. I'd be a little hesitant to use the 014 or 018 version from below, considering the fact that it's not entirely clear how much distance from the ostium of the AT we are up until the popliteal segment. So that angulation has to be accounted for somehow. But to try the 035 system from above, I think is a very interesting idea.
Yeah, so we're just Ray's just getting it down. You
what
can
you
go ahead
need.
and help him get it down with Ray. So Ray's just getting it down there with Vishal, and we're going to come from below. I'm going to continue to work from below. I think it's nice that we have the wingman here, and then we can actually poke it and then use a wire to get through that. So let me go ahead. I'm coming from below just with the command wire because he was having pain in the foot when we were pushing. So that's part of the reason why you might need a sheath as well.
Yeah, I was gonna say.
So this is the area where I'm just going to just kind of advance just a little bit to about there,
Go.
and then try to maybe do some sort of dissection reentry here. There you go. I don't know where that's going, but I'm just going to take it for now.
No.
Let me just take it for now. Let's see where the hell that's going. Look, let's see. You never know. Let's just see what's going to happen. We'll just be careful. We won't inject. Okay, I'm just going to put this here.
Love it.
Okay, I'll just put this here. Let's do a DSA from above here. That's the wingman there, Ray?
Yes.
Okay, hold on.
That's very that's interesting.
Let's see where we are. You know, that's why we give some dye, see where we are, whether we're in a collateral. I mean, that looks pretty promising. It doesn't look like we're in a collateral. Looks pretty good to me. Ah, looks like it may be a collateral. See that?
Yeah.
See the collateral?
Looks
Yeah.
like we may be in a collateral right there. See that?
Yeah.
So that's maybe a collateral heading back south.
So at least now you know where your
common.
P3 segment is. So I guess you've learned two things
You
here.
could take that
What is
out.
this?
Why does that?
You've found your
That's wingman
P3
right there.
segment,
And you need a glide wire in there, right?
and it also looks like you have like about a centimeter of your AT ostium that's still occluded. So you have, it looks like you still have a little bit of a distance left to go up
Yeah,
until
so-
you get to the true ostium
no
of
question.
the AT.
Dave,
So what I'm going to
You got
do
stiff
here,
line
Roman,
in
I'm just
there?
going to mag up here. I want to show you this
you got
needle.
your stiff lines
We,
up there?
it
Yeah.
looks like we're in the right area, so I'm going to throw the needle, right? So here's the needle. So there's the
we need
needle
that
that's going
positive.
out.
Yeah, and then
Let's give me some positive.
So
positive, and then from the back end, as you twist it, you kind of make it a little bit of a drilling segment to kind of drill. Now, the only challenge part with that I've seen with this device is that it works best with a two-person system. One person kind of keeping your positive, other person
Careful.
drilling from
Let
the
me-
back, and then then both.
I
in
just don't. I'm
unison.
not convinced I'm in the right area now. So because it kind of moved a little bit.
I'm going to give a small puff from
So
top.
maybe we get a little. We can puff through here.
255.
Oh, okay.
Just puff through here. So I'm just going to puff it through here, and then we'll see where we are, and then we decide. I just want to be in the right area. I don't want to be in a collateral or anything like that. And no, I'm okay. I'm in a
Yeah.
good spot. All right, now we're going to go ahead. Give me now we can put the 035 wire through here, right?
Yes.
So let me
that's
just
what
go
we did.
ahead, push. Okay, ready? Positive, Ray?
Yeah.
Okay, push. You can see how hard that is, Roman. Look at that.
Yeah, but now see
Right.
from your end, PK. I think at this point, drilling more with the back end to kind of make a little bit more of an actual pathway, I think would help. So if you rotate the little piece that's in your left hand.
Yep, I am
So it kinda
rotating, but
makes-
I'm going to go with the glide now because we're positive and we got a sharp edge there. So now you can see the
Yeah.
edge, and I'm just going to try to poke through with the glide here. Let's see if it actually works. Everything is good in theory. See, there you go. There's the theory, and there's no result. So we're going to pull back again. I'm going to torque it. Okay, Ray, positive again, buddy.
Yep.
Is this a straight or a stiff? You guys know?
That's
Stiff.
That's just stiff.
Stiff
Stiff
straight?
straight.
Oh, wow. Hold it there, Ray. Okay, one more time. Okay, well, hopefully that helped a little bit. I definitely will try again here.
Very fibrotic with calcium.
Very fibrotic. There you go. Mr. Wingman, sing me a dream.
Oh, did you feel it?
Right?
Oh, yeah, if you got a little bit of.
All right, at least we got a little bit of purchase
Yeah.
here. So now I'm gonna. Is he okay, Liz?
Yeah.
There you go. I'm
Nice.
just getting a channel here, Raman.
Yeah,
I just want to
and
get a channel, and then once I get a channel, I'm gonna go ahead walk the Wingman out now.
just tell me, just so I can understand, you had the back end of the wire here,
No.
No,
Regular,
regular.
the front end. Okay.
Yeah.
Yeah. So
But
now
he
need
just
a-
changed the
That is-
needle. Right, the direction
So
of the
now
needle
I
he
need
changed.
a
it.
Terumo Navicross, guys.
We got it.
So now I'm going to go with the Navicross from above. All right, so Wingman helped us, did its job. But hopefully we're in the right spot. We'll find out soon enough. So now we're going to go with the Navicross, create a channel, and then I'm going to go with the other wires now. So the whole idea was to break the cap, which we have. All right, now we're going to go ahead. Thank you, Ray. The wire's not out yet, but
Okay,
that's
good.
fine. Okay, so now we cannot lose this. Now, whether it crosses or not, we'll see. But we'll just try to get it down there. At least, yes. All right, we're at least through something here.
Wow.
Okay. All right, good. Now give me an angle
Once
glide
again,
wire
hold
now.
pressure.
Now give me an angle
Stiff angle.
angle glide.
Let me get a new stiff angle.
Yeah,
I'm just
stiff
going to
angle.
dissect it now, Roman. I don't,
Yeah.
for me right now at this stage,
Stiff angle.
Let's
Let's
cross
get to where-
somewhere and then figure it out afterwards.
let's get to
I
where we're
agree.
going here.
We want to
It's
pull
to-
back the AT wire because.
Yeah, for now. Yeah. Well, yeah.
I'm
you
gonna
can
put it
pull
in the
back. You can
regular
pull back
lumen.
now. Yeah, I agree.
Try to
So pull it
in
back
the-
and let it just.
Stiff angle.
Is it a new one? Good.
Not a new one.
That's
No,
fine.
no, give me
This
the-
is fine.
It's the tips.
It's actually in good shape. All right, give me a torque on this, guys.
Sure.
All right, good. So now we're just gonna. Now I may pull back and forth, Rum, and try to get a different channel, and then try to go here with an
Yeah.
angle glide. Let's see. how
We're,
this
and we're in a
goes.
very different position than we were just 15, 20 minutes ago. So I think this is
Yeah.
a very good start.
Mm.
That's interesting.
Yeah,
Yeah,
it's very.
that's not a good sign. Don't push straight, pull back now.
Pulling back.
Yeah, no, that's bad. We're in a collateral, see?
Yeah.
Collateral.
Give me the
Oop.
introduce.
Yeah. So you're feeling a little bit of pain, it appears as such, no?
Pull back, right? Yeah, that's a
Give me
collateral.
introduce.
We got into a collateral, Roman. Collateral.
Really?
All right, hold on.
Yeah.
Yep, hold on.
Can I have an Ostado? Give me an Ostado from here. Yeah. No, 30.
Mhm.
Okay.
Hold on.
Okay.
Give me a little dye here, guys, in a syringe.
Mm-hmm.
Hold this. All right, so.
I always have to be wary dealing with these complex CTO segments because, they can still bleed.
Oh, yeah.
Yeah.
Yeah, especially the popliteal part. You're right. The anatomy,
Yeah.
so can
Unforgiving.
be tricky. Yeah.
Yeah.
Thank you.
I'm getting no blood from below here.
Below or
There.
above?
Above, hold on. Hold on, Michelle, let me get
Yeah,
this.
I'm gonna wait. Don't worry. Well, just do what you gotta do. Maybe take a good picture right there.
Oh, we're good right now.
I'm surprised it popped into the collateral because it looks. See, you can actually create a little bit of track there.
And that's what we were
Because-
trying to do.
yeah.
I think we went the other way. You see the perforation, a little bit of dissection.
Oh yeah, you're right. Going more
Yeah, that's
medially.
why I was worried. See that?
You're right.
Yeah, that's the wrong spot.
Maybe we go back to our 018 wide and see if we can loop because we have a
This is
channel.
better.
Maybe it'll just scoot
Hold
through
it there, Ray. All right, give me the glide now.
Definitely a lot of contrastasis here.
Yeah,
Oh,
let's turn off the
definitely
max,
so.
Lizzie. No, senor. Is he okay? Is he having pain?
I think it's just.
Yeah. Would you consider taking like yeah. How does it feel?
Nah,
No,
fine.
right now it's
This is
very
nothing.
soft. I'm just
Yeah.
trying to get the stain off, just get it off the view by just massage a little bit. But again,
No, it's not going.
uh,
Positive, right? Like that.
you have the Astado?
Give me the starter from above, guys.
Fine. Well, okay.
You don't have a 30? You don't have an starter 30? I tell you, it's very difficult
All
to
right,
work.
given 20 to him. Fine. Better than
know.
Confianza. See. No 40 as well? Okay.
Can you call Juanita, please, for me?
That's proper.
Yep. I'll keep it off for now. It's okay right now. It's not.
Yeah.
Okay.
That's your Astado right here. Let me
And now I'm
try.
coming with the stiff end of the glide here.
Hmm.
Oh, yeah.
Right, you got to keep it jammed in there. Yeah, it's moving. Nope, it's not going. It's going in the wrong direction.
Yeah.
I think so far the one thing we've learned is that this is really hard.
I think that's it. Give me the
Yeah.
shot now.
That's a
Now, I will say
correct
this for everyone at home: if you find yourself reaching towards the back end of a wire, it's always a very reasonable point to take a step back and say, "Do I feel
Give me
comfortable
another
continuing
Astado
with this?"
for me.
And a lot of people, it all depends on how complex cases you see, but. Reaching for the back end of a wire should be done only if you've done it before, or you've experienced the way how it actually maneuvers, what it feels like, and you've dealt with the complications associated with it. But this is in PK's hands. It's a much safer tool than in a lot of other people. So again, routinely, this would not be the beginning choices of your wire escalation.
No,
if it
see,
is
this
a
is
part of
it's
your-
not even close, Roman. Look at this.
Yeah.
It's not even close.
Let me go back from.
I
below.
think we're gonna put a sheet below and come and try one time from below with an 035 system.
Yeah, I agree. I think this
That's where we were
has.
before.
I think this is kind of proved itself to be a case in which the cross is going to have to be retrograde. The only thing which is of a little bit of concern is that this contrast has actually increased in its development.
Yeah, but it's staying in a pocket, so I'm okay. It's not really expanding. So what I'm going to do now is come from below. I think we just work solely from below now.
Yeah.
Give us a what wire?
I have an Astato here.
Yeah, let's just
I
go.
think I would try with an Astato with a bend on it, so hopefully.
And then let's see if it goes in there. Because if we can get some purchase here, it'll be wonderful. But we'll see whether we get there. We go.
Right there.
There we go.
Right there. Hold on. That looks better. Yeah.
Hold on. Let me just try to get some.
Yeah. I'm just gonna give you positive tension because remember with the no sheath, it kicks you back.
Yes, this looks beautiful.
Oh, we don't know, but we'll see. Let's get this up now a little bit, Vishal, if you can.
Yeah,
I don't. You might need a sheath. It's not gonna go. All right, we're
I
gonna
don't
need
like
a
it.
sheath,
You
guys.
just have to break that
Yep.
same problem with the
Or
fibrotic.
give me a
4-5 slender. Yeah.
yeah 4 or 5 slender, which we have.
Yeah, we have it.
Leave it right there.
You can't put a slender on this though. This is an 018 wire, 014 wire.
Oh, but it's a stiff wire.
I'm in
The wire's going somewhere.
What does he feel?
Dolor, señor.
The foot.
¿Sí? ¿Dónde?
Right here.
¿Abajo o arriba?
Where?
In the ankle? Okay.
Yeah. it's
I'll
not-
give him more
Yeah,
local lighter
walk
right
this
there.
out for me.
Yeah.
This catheter.
Hold on.
All right. Give me a
Flora? Flora is on?
Yep.
Let me just. Can you
walk it out.
can you pull the catheter for me a little bit because it's going to tuck at the angle.
Uh-huh.
Yeah, give me a little bit of help. Thank you.
I wonder.
I know it looks a little bit
at
off.
a catheter if you're in that collateral again.
Oh, I don't think so. We'll take a
Did
picture.
the angulation change here?
Yeah, he moved.
Yeah.
Yeah. Okay.
Yeah. It looked a little off, very off, right? This,
Let it
Yeah.
bleed out. All right, give me a Cook wire now. Cook 018 Cook. What is it called? Crossing catheter. What is it called?
the CXM.
Yeah, give me a CXI, guys.
Shit.
What was it? Is
Gonna
it
try the sheet. Test the dilator and then
not a
the sheet.
sandwich?
With what?
No, I'll put a regular dilator and then you think it's gonna kink? Okay.
The other concept is whether if we're convinced we're in the correct
Very nice.
popliteal segment from below, maybe to try the wingman from below. It would actually be a 014, 018 system from
What
below.
I'm going to
see
try
how
to
that works.
do now is I'm going to try to go with a this one now. I'm going to try to go with a Terumo
Gold.
M wire, gold
Yeah.
tip wire, and try to see if I can loop it and try to see if that takes me to where I want to go. You got the wire?
Yep.
Pull. Okay. Okay, senor. Just a rail, please. It's not going.
Yeah, that's how you need to put a.
Ah, it went.
I'll photo for you. Don't kill your back.
It was going. No, it's not going. I think we're gonna have to put a sheet here.
Yeah, that's what I'm saying.
Yep. All right. Give me the Cook sheet now. The Cook pedal sheet. Give me the Cook pedal sheet, guys.
It's a regular sheath, right?
Are you going to go with 4.5 or 5.6?
Well, no, we're just
The-
gonna
the
go with a
Cook-
Cook sheet for now. I just want to get more purchase and prove to myself I'm okay, Raman, before I put a real sheet in.
Mm-hmm.
So I'm just gonna put a pedal sheet in right now. After the pedal sheet, I'm gonna decide, what I want to. This is what 3 French, right?
Yeah.
So
2.8.
2
It's
point.
actually a 4 French for the dilator. It's 2.3 in, but it's 4 French really.
So 4 French, so we can put a lot of stuff through here.
Yeah, hopefully.
So
That's why I said the 4 also. 2.3.
okay, so that
Let's see how
went.
it does. Yeah.
Okay, now
I'm gonna give you the cap.
uh-huh. Okay.
Give me open this.
Hmm. Now, once we cross, what do you think about as far as your final therapy here?
Well, I think first will be balloon angioplasty, and then kind of see, and then IVUS, see what the hell's going on with it. Based on that, we decide.
Yeah.
Let's see what microcatheter can go through.
Okay,
this.
now put the CXI through this.
Yeah.
I think it's gonna be very hard to get away from this.
Yeah, no.
Without a stent.
Oh yeah, there's no question. I think, but I
BCP
mean, I think.
Supera.
Well, let's first, like I said, this is where I think Vibes is going to make a difference. But David's got a presentation while we wait, so I'm going to have David give the presentation, so this way people can learn something as we're struggling here. So Ray, can you help David out so this way he can give his presentation?
Yeah.
And we'll continue to work in the background. Go ahead, David, give your presentation. Oh, wire's back. All right, show me above. No, don't worry.
Can we go back to the
Just
slide,
rail the wire.
please? Next slide.
It's not going through this.
You need a full regular sheet then. It's not probably gonna go.
All right, next slide, please.
I'll put a regular.
So one of the seminal PAD trials that was concluded this year was the Life BTK study. This was a
All right, give me a
randomized
V18
controlled
wire
trial
and a
that looked
5.6
at
slender.
261 patients.
4.5, 5.6.
That
4.5 is
compared
fine.
4.5 is right there.
V18,
Let me give you.
V18.
You want a V18?
versus PTA. And this study was actually one of the major contributors in the study was actually Dr. Crestor. Next slide,
Hold on,
please.
let me give you an introducer.
So in infrapopliteal disease, there
New
have
V18.
been multiple interventions studied, including bare metal stents, DES, atherectomy, DCBs, angioplasty. But all of these interventions for infrapopliteal disease have not been able to consistently demonstrate consistent inhibition of neointimal hyperplasia. It has not been able to demonstrate resiliency in scaffolding below the knee, and it has not been able to demonstrate potential promises in technologies that can potentially leave nothing behind, which would leave bypass as a potential option for patients down the line. Next slide, please. So the Life BTK trial really tries to fill all of those gaps with a novel technology with the Aspirit BTK drug-eluting resorbable scaffold. This is a temporary scaffold that will fully resorb over time. This is composed of a polymer backbone, and it's comprised of an active pharmaceutical ingredient, which is an everolimus drug, and it has 4 platinum markers that allows you to definitively see the stent under angiogram. And this is like a monorail system, similar to a coronary delivery system. Next slide, please. So the objective is really to evaluate the safety and efficacy of this BTK resorbable stent system compared to PTA in the planned treatment of disease infrapopliteal lesions in patients with critical limb ischemia, up to 2 de novo lesions in separate vessels. Like I said, this is a multi-center randomized controlled trial. The safety endpoint at 6 months was defined as male, and the efficacy endpoint at 12 months was primary patency rates on non-invasive imaging and also limb salvage. And the overall follow-up for the study was over 5 years. In terms of the patient population, it's very similar to previous PAD trials, multiple comorbidities, more males, and overall the patients were critical limb ischemia patients, Rutherford class 4, defined as rest pain, and also Rutherford class 5, defined as minor tissue loss. Next slide, please. The overall lesion characteristics, the main thing to know is that these are all infrapopliteal lesions, and the main thing that was really pointed out as a potential limitation of this study is that the lesions involved in the studies were overall shorter to what you would commonly encounter in clinical practice. But everything in terms, every step of the study was adjudicated by a core lab in terms of lesion definition, wound definition, and overall non-invasive study, adjudication as well. Next slide, please. So the patients were randomized in a 2-to-1 fashion to either the Aspirit BTK treatment resorbable scaffold group or also PTA treatment. And basically the treatment of these patients required pre-dilation of the lesions with a 1-to-1 pre-dilation balloon. And then for the Aspira BTK arm, post-dilatation must be performed for all scaffolds, and intravascular imaging was required for most of these interventions. A successful target lesion treatment was defined as a final diameter stenosis less than 30%. Runoff was preserved pre and post treatment. There was no residual dissections, and there was no transient or sustained angiographic complications like embolization, no runoff, no reflow, perforation, or thrombosis. Next slide, please. So basically, the overall efficacy endpoint was met, demonstrating superiority of the BTK bioresorbable stent compared to angioplasty. And in terms of the final safety efficacy, the BTK resorbable stent was non-inferior to the angioplasty. Next slide. That's essentially it in terms of the BTK study.
All right. So what are any thoughts, Robin? Okay, stay there. Good.
Yeah, so I mean, it really is it's a great review of the paper. I think, you know, again, where we are with this, with the below knee disease is there is a great need for being able to actually treat this in a very effective manner. And I think, you know, what we've proven is that over time and time again is that the next frontier is really trying to maximize the treatment strategies and what we can deliver in the below knee segments. And I think this is kind of the beginning of the storm where we're going to be looking at these new Limas-coated technologies. I like the fact that this is an absorbable scaffold, because I'm a fan of the idea of not really leaving anything behind. And I think this is a very promising start. I think there's still a lot of work to be done. I think there's still a lot of possibilities and technologies that are going to be available to us. A lot of trials that are still ongoing. And I think this is it's a very promising start. Definitely looking forward to kind of what's coming down the
Is he complaining? At the foot?
Aki, here? Where I'm pressing with my fingers?
Yeah, at the foot.
Can I have some lighter? Give me a little bit of lighter.
So, Raman, I agree with you, everything you're saying. I think the problem is, you know, we have a lot of promise with this study. Everybody's excited about it. The only problem I have with this study is that obviously we participated in it. We had a lot of patients put in it on our group. Hold it, and that's not it. I don't think that's it.
Yeah,
I'm going to go a little bit to the other side,
yeah.
pull back. I think the issue here is that it's not a question of our group. It's a question of the Fed. Yeah, that's what it is.
Yeah.
See, that's what I don't want.
That's
Hold
the
on,
collateral.
let me
Right.
say. Is that it's not a real world representation. So, you know, and also the stents itself are shorter stents in these tibial lesions that are quite long. So I wonder how it's going to translate into our everyday practice. This is what worries me personally.
Yeah.
Is how does it translate into our everyday practice? You know, at this stage, sure, we've got great data for the first time. Everybody's excited, including myself, that we were able to actually, you know, beat PTA in something, right? But looks like at this stage, you know, what does that mean? I mean, does that mean that we're going to use this in every single, you know, below knee stent that you and I do? I doubt it.
Yeah.
Does it mean that?
I mean, like I think it's paved the road for further questioning and to kind of allow some justification to using Limas technology. I mean, like, I think this stent is going to cost like $3,000. I mean, this is going to be.
Well,
this
the cost
is
going to be a major issue for sure.
Major issue.
Yeah.
You know, and I think that's, you know, and I don't think I've completely agree with you. This is not going to be something that's going to be routinely used up front. I mean, how often are you going to use, like, you know, 4 of these stents for, like, you know, a 200 millimeter CTO segment? I mean, that's very unlikely. As far as the data is concerned, there's promise. I think there's still a tremendous amount of work to do. I think we've just opened the door just a little bit. And we're getting a little bit of light in the field.
So I think for the audience at home, I mean, I think, listen, we don't fail often, but this one I have a feeling like unless I'm willing to perf this vessel in a claudication and hurt him or her or hurt the patient, which I'll never do, is we have to understand that, you know, at this stage, a short bypass, even though it's PTFE, may be the right thing to do here. So, you know, I'm going to give this a little shot here a couple of more times. And then, you know, I'm using my different wire technology here. I think we have to flush a little more in the back. And then so we have an 035 system now from below.
Whoa.
And we are now going with, we haven't done the 035 glide yet, I'm going with a 035 Navicross in this large, robust vessel. And I'm going to go with a Terumo Glide because I'd like to dissect, but I'm not able to find the lumen. So at this stage, I'm just trying to see.
Would you also consider putting another wire into the coronial, so at least you can have like a second kind of marker, so you see how far away your TB trunk actually is. And
yeah, I mean that's possible. I mean, we were in a really good spot just a second ago, and I pulled back like an idiot. But give me a torque around this one. So I think I'm just going to work a little bit for another 5 minutes. If I can get any purchase, I'll go ahead and try to finish the case. If not, we're going to call it, and we're going to just send it to our good buddies, our vascular surgeons, to do a bypass, because I think he'll do really well with a bypass. I mean, this is I think a classic attempt at trying to revascularize, percutaneously, but this one is clearly a more of a surgical case, it looks like to me.
Certainly could be, yeah.
Yeah, I mean, listen, we could be super aggressive. We could do back end of the glide here. We could do anything we want, but we're not able to make that turn up, which I just did a second ago. That's not it. Pull back.
No.
Pull back, please.
Yeah.
Pull back. Floor.
I am.
So let me just see a few more minutes here. Since we have a few more minutes of satellite time, let me see whether I can just make it turn. There it was. Just started turning there. Let's see if it turns there.
So maybe we try the Astaro, try to direct it up, get the catheter, and then you'll loop it. I mean,
yeah, that's what we can try.
Open the Astaro 30.
Let's try the Astaro one last attempt.
Yeah. So you had the beak and a little bit of traction there. So if you can repurchase our land right there, and then like PK talked about, loop it, and then you're right. The turn is what's killing us. Yeah.
It's the turn up.
Yeah.
At least we think, like Raman said, the other problem is you don't know where is the actual end of, there it is. Okay, let's see here. Hold on, let me just see if I can get a little purchase here.
No, I have to go.
Try to get forward with the catheter.
But the problem is my prolapse. Okay, I'm gonna go slow.
Keep going. Keep going.
I'm right at the hub.
Yeah, that's all you can do here. Let me just see if this thing. Nope, doesn't want to go. I'm pushing real hard here.
I think that's the right direction. It looks.
There you go.
Don't you okay, sir?
Oh, it doesn't really. Let's see.
Yeah,
okay,
yeah.
Okay, hold on.
I'm gonna keep forward.
I'm just gonna try to get some here. Hold on. Hold on. Not really happy there, but let me see.
But
it's going anywhere it wants to go. But I'm definitely in the vessel for sure. Now is when you want to. When you kind of want to see where your catheter is above. Not unreasonable.
Yeah. Sorry.
I just don't like that it's going towards the fibula there. Well, let's see here.
Let me try to see if I can drill in a little bit.
Let's just see if I can get a little more purchase here.
Sure.
No mueva, señor. No mueva.
¿Dónde está dolor?
Dolor? In the foot or in the...
You have to ask him specifically.
Yeah, no, Ramon is asking. Back of the knee or the foot?
In the foot. Why am I having so much pain down there?
I mean, sometimes I've seen if you're pushing a lot and the wire is moving a lot, sometimes the catheter actually buckles in the mid-calf.
Yeah.
It's going to prolapse everything.
Yeah.
Which is always a concerning thing to see, but it has happened a number of times.
There, it's going in the wrong direction there. The only thing to do is maybe try with a stiff glide and try to see whether we can reproduce this thing. Give me the stiff glide now. Last attempt. Stiff angle.
Take the Astaro.
Give me the Estado too. Let's try the Estado. Let's try the stiff glide and then the Estado, and then we call it. Give me a new stiff glide, guys.
This is the stiff glide.
Give me the Estado then. If you don't have a
stiff angle glide.
This is the stiff. This is
stiff angle glide.
Give him the Astaro first.
No, this is the angle.
Yeah, that's fine. That's what I want. I want the stiff angle glide. And open the Estado 30 for me.
It's open.
Good. That's fine. So we fell from above, are failing from below.
That's a soft.
So, we need to find out why this is happening personally. Pull back a little.
Pull back? Sure.
That's a good sign. Pull back the catheter.
Pull back, sure.
Parker? These are all 10 out of 10, so.
Yeah.
You
chose a tough one today.
Well, we usually do, right?
We wanted the special for the holidays.
For Christmas, yeah.
Yeah. No, but like PK talked about, you have to be realistic as well. Of course, we want to give the full opportunity to the patient, especially being a clotting, and try to see if we can get a bypass. Because we know here we can put Supera with good results and all. But like you said, it's not unreasonable to call the surgeon friends.
Well,
Yes.
they're aware. I mean, they're fully aware of what's going on. It's not
No,
like
just from a practice
yeah, I mean,
perspective,
this,
like
I
you talked
said,
about.
this is a patient who is a nice candidate for this, for a short bypass. You know, so why wouldn't you call
What
them?
flight is this?
You know.
I have no idea.
Let me try.
What is that? Oh, it's
What
not.
flight?
Yeah, you can work from above.
Well,
It's not. Believe me, from above is just. Okay. There.
Where it looks as if you made just about half a centimeter of progress.
That's what I'm saying. Can you imagine how difficult this is?
I know.
Hopefully Vishal is able to get somewhere. We can, but regardless, I think at this stage,
yeah.
it's probably better for him to have a bypass.
Same spot.
That's the same. That's a perforation.
Okay. Yeah. Okay. Just the wire, not the catheter.
Señor, no mueva.
Pull back.
Ask me where the pain was.
Yeah, that was the perforated segment.
Yeah, that's why.
Where's the pain in the foot still? Or by the? Or by the knee?
Wow. No, it's the angle, Roman. The angle is killing
Yeah.
us. No. No.
Yeah, it feels
I
like
don't know.
just
I'm
pretty
not
much tries
happy
to
with
go
that.
out. Yeah. The tangentiality of that vessel, the wire.
I think we're going to stop, guys. It was a good case. I think it talked about different types of wire escalation. I think in this situation, I think it's better for us to, for the safety of the patient, safety of everybody, says, let the patient go to surgery, have a good result surgically, and then be done with it. You can see the robust collateralization with no perforation. I think we're just going to do a short bypass here and let it be. Everybody agrees?
Yeah.
Sure. I think that's
Valiant
So,
effort.
You hate to fail the last case of the year and the only case of the year, but it is what it is. I mean, it's a very difficult popliteal occlusion, and we're going to stop here. So I hope all of you have learned, I guess, not only the different attempts of wires, catheters like the wingman, but also really to understand when you need to call it quits. So this is definitely an area where I'm not comfortable anymore to try to push anymore. It's a very short bypass from distal fem to the AT. Great runoff vessel, I think, with the 450 vessel, patient level or a long-standing relief from his claudication. So we're going to stop here. We're going to call our surgeons. Thanks, anyone. Thanks, Vishal. Thanks, David. Thank you, Ray. Thank you, Ramon. Thank you, Liz. And thank you, Damien, who's not here, as well as Habibi. So have a happy new year and a happy holidays. Thanks, guys.
Thank you.
All right, good. Hate to fail, but we did.
Yeah, well.
All right.
All right, guys. Well, it's never a dull moment here. Still definitely always a lot of great teaching moments and teaching points here to learn even with failures. That being said,
I tried my best.
thank you for joining us, and we wish you all a very Merry Christmas and Happy New Year. And now, next step, we'll look forward to seeing you in January 24th, 2024, with our next live case, first of the year. Take care and be well.